Hi everyone, and welcome to this evening's webinar. Tonight we are going to be talking all about clinical supervision. Now, there is a bit of a story around why we ended up here today, and it was all because of an interaction on Twitter, and one of our physical health colleagues was just saying how she didn't feel that she could speak to her peers or her colleagues about the situation she was in at the moment, and nor did she feel like she had the access to that clinical supervision, and from that is how we are here today. Now, I'm going to hand you over to each of our guests because we do have a number of them, which is great. And to start off, if we could introduce ourselves, and I'm going to hand you over to Tony.
Hi everybody, my name is Tony Butterworth. I'm a retired Professor of Nursing and Dean of School. I'm a registered mental health and general nurse and a lifelong interest in developing and working with clinical supervision. Thank you.
Thank you, Tony. And next we're going to hand over to Kath.
Hello everybody, I'm Catherine Gamble. I'm the RCN Professional Lead for Mental Health and I'm also the Head of Nursing Practice Education and Research at South West London and St George's Mental Health Trust. And I'm passionate in ensuring that nurses get the support they need and deserve in order to be able to practice effectively and with compassion so that they can actually serve the people that we work with, their families and their friends.
Thank you, Kath. And next up is Gemma.
Hi everyone, good evening everyone. I'm Gemma Stacey. I'm Director of Academy at the Florence Nightingale Foundation, a mental health nurse, and I've done lots of work around clinical supervision as a means of facilitating transition to practice from student to newly registered nurse. So looking forward to sharing some insights from that work with you this evening.
Thank you, Gemma. And next I'm going to hand over to Antonia.
Yes, thanks Jess. Hello everyone. My name is Antonia Boama. I'm a member of the Lived Experience Carers Family and Friends Reference Group for the RCN Mental Health Programme, and soon to be a crisis support worker at the South West London and St George's Mental Health Trust. So I'm new to the healthcare profession, and I'm very much interested in clinical supervision because I think I will be needing quite a bit of it. Thank you.
Thank you, Antonia. And now I'm going to hand over to Ellie.
Hi, my name's Ellie Gordon. I'm Senior Nurse for Learning Disability and Mental Health in the National Nursing Programme at Health Education England, and I'm also a member of the Royal College of Nursing Mental Health Forum. And to be honest, in both roles, I've been a long advocate for clinical supervision, mainly because I've seen what a difference it can make for myself and for my colleagues in between somebody who can be the best you can be as a nurse, but also the best you can be in your personal life as well. I think it really helps you to get the best of both worlds and have a good work-life balance.
Thank you, Ellie. And now I'm going to hand over to Phil.
Hi, thanks, Jess. My name's Phil Huff. I'm a carer. I support my brother who's had a long-term severe mental health condition, and I'm also the vice chair of the Mental Health Network, which is part of the NHS Confederation, and I support the Royal College of Nursing in its mental health advisory group.
Thanks very much, Phil. And now I'm going to hand over to Emma.
Good evening, everybody. My name's Emma Wadey. I'm the Head of Mental Health Nursing for NHS England and NHS Improvement. I'm also a consultant nurse in Psychiatry Liaison. I've done lots of work over the years around clinical supervision, particularly its impact on how we maintain professional boundaries. And more latterly, as both a supervisee and a supervisor, thinking about the role of clinical supervision to enhance our mental well-being and enable us to continue to keep ourselves well and continue to look after the people we care about.
Amazing, thank you, Emma. And we also have on the line as well Beatrice Stevens. Now, unfortunately, we've had a few technical issues with Beatrice, but she is very much with us still, and she will be able to give us some of the answers when we do publish the Q&A that we'll get as a result of the questions that our audience will submit after this. And last but not least, it would be wrong of me not to say who's there in the background from the committee. We also have Heather. So Heather, do you want to say hello? She's gone shy. She's too busy with the Twitter, I'm afraid, guys. So the format of this webinar, if you've been with us for our last couple of webinars from RCN Students, is going to be slightly different. So we are going to start off with a presentation, and we will make this presentation available to you as well. And this will be delivered by Tony, Gemma and Kath. After the presentation, we have a few questions prepared for our guest panelists as well in regards to clinical supervision that we've prepared in advance. But then we will be opening it up to our audience for any questions that you might have in regards to clinical supervision. So please, as the webinar goes on, please submit your questions to us, and we will try and answer as many of those as possible at the end of the session. And any questions that we are unable to answer this evening due to time limits, then we will publish those, as I've said, on RCN Students' social media channels, but there will also be other places on the internet where they'll be available too. So without further ado, I'm going to hand over to Tony to start the presentation.
Your microphone is muted, Tony.
I'm now seriously unmuted. I hope everybody can hear me now. Just to show you on this first slide that we've got these nice little motifs and logos, and from now on I'm Tony the Bee Butterworth. After me will follow Gemma the Butterfly Stacey, and then Kath the Dolphin Galmel. Gemma and I started to think about how we might develop and enhance and interest people again in clinical supervision in these slightly troubled times. And then, of course, we engaged with the presentation that we're here doing today, with people who are students, with people who might be supervisors. So we're aiming it across the board. But there's no doubt at all that clinical supervision in troubled times is very, very necessary and important. For those people who you may come across who are non-believers in clinical supervision, it's important to say that the evidence base is very powerful. So all the research which has gone on has shown in terms of its educational support, in terms of interpersonal support, and in part a positive impact on people who use services who are looked after by nurses who receive clinical supervision. Next slide, please. First thing to say, and again please, is to say thank you very much for thinking about this. The fact that you're here means that you've been taking time to think about clinical supervision, and you've taken a very positive first step. Next, please. So if you're looking at this material and you've collected it, then that's a very positive thing to have done. And there's no doubt at all that nurses will be glad of supervision support from other experienced nurses, particularly where there is none available from elsewhere. And it is true to say, I think as we started at the beginning of this presentation, to say that there are people who cannot access clinical supervision. You might not yourself be working on the front line, but it's important not to be shy. Many frontline staff have understandable and familiar questions and worries that we're still familiar to experienced nurses. So to start a conversation with people with experience is easier than you may think. Next bit, please. These are very unusual times. We all know that. But the need for support through clinical supervision has absolutely never been greater. Next slide, please. If you're a bit like me, you're overwhelmed with information on the COVID pandemic, and you'll find it everywhere. But to search through that for particular areas that might be of help and interest, we've offered 3 here. The RCN itself, of course, offers a really good regular update on matters relating to the COVID pandemic and nurses working in it. The British Psychological Society, the BPS, have got a really helpful piece on the psychological needs of healthcare during the pandemic. And you will hear, as I have heard, people bandying about the mental health avalanche which is to follow. Well, I think the BPS piece offers some really useful advice on how to prepare for, how to work with people in distress. And thirdly, if you look there, our NHS People and Skills for Care offer a range of services from both phone lines through to one-to-one psychological support. Next slide, please. Because I'm as old as I am, I've been in contact with many other nurses who are now retired, and if you see and have conversations with them, you know there's a sort of frustration where people want to offer some help and support to people working on the front line across all specialities and locations. And we wanted to say, well, perhaps through this presentation and the proceedings of this evening, we can offer some revision and some support. We wanted to offer something to nurses, retired or in practice, who wanted to provide clinical supervision to those working in a clinical setting during the pandemic itself. And so we have several objectives for this material. The presentation offers us a source of advice and support to get a better understanding of the current context in which clinical supervision might take place, how to make yourself available to those in need, but also how to make yourself available to be supervised, to try and differentiate between expert supervision and counselling. And for those people providing clinical supervision, how do you know if you're going to be a suitable clinical supervisor? A little refreshment on the key components of supervision, and then you yourself, if you are a supervisor, getting some kind of debrief support. Next slide, please. So how do you know if you'll be a good supervisor to start with? Next, please. Many people I've talked to say, well, I'm not working on that front line at the moment. I just don't know what it's like. They will know more than me. And that's really easy to be paralysed by that, but you must not be overwhelmed by imposter syndrome, because many people will have had significant experiences that will help you locate and drive through clinical supervision support. A lot of the questions will not be unusual. Clinical supervision is about listening and reframing what you hear and offering reassurance and expert reflection based on your own experiences. So you do have great value. You should not think of yourself in that imposter category. Next, please. Also important to say, though, for people who have ambitions to be a supervisor, if you try to supervise but find the experience too difficult, then just withdraw gracefully and by mutual agreement, because at least you tried. You gave it your best shot. Next, please. So how might you make yourself available? Next, please. For supervisors or people who wish to offer some kind of supervision, we feel it's really important to let people know that you're there. There will be people like me and the organisations around where I live in Greater Manchester no longer know I exist. So unless I know, I can let them know that I'm here and I'm willing to support and be helpful, then nothing will happen. And to support one team, or at least no more than 2 individuals, would seem to be quite sensible to begin with. Next, please. So let them know that you're around in the local trusts. Many of them will have been through reorganisations in order to deal with the present circumstances. So finding out where people are and what the best contacts are with those senior nurses is quite important. Next, please. The same applies to nursing homes and care homes within a geographical area that you might know. I'm a trustee of a charity in Trafford offering counselling to children and families, and there are 33 care homes which surround the small geography of Trafford. Their need is considerable. They do need support and help. Next, please. Well, it seems silly to take now, but you might want to offer a video conferencing platform like this, which can be more accessible and helpful while social distancing is in place. So, like me, who always approach IT with some nervousness, then this clearly is a possibility to take advantage of. Next, please. These are most unusual times, but the unprecedented experiences of the COVID panic, they're just not normal, and people will require additional expert support and comfort. The work of nurses is always difficult and emotionally demanding, and no more so than now at this present time. Nurses are seeing and experiencing such difficult things at the moment. You'll have seen perhaps on TV last night a really useful presentation about work in 2 care homes where people were seeing 2 and 3 and 4 deaths per day. And the emotional burden of that must have some discussion and to be shared with others is really helpful. And the stress and distress experienced by people is really very real at the moment. But they may not need more formal psychological intervention. Some sustained supervision may be enough. But, next please. It's really important that you yourself have contacts for personal counselling and psychological support to hand. If in your judgment you think it's necessary to find additional support for individuals or for teams. So proper counselling, if you like, should always be to hand. Next, please. So my colleague Gemma will now take over from me. Thank you.
Thanks so much, Tony. That's a really helpful introduction to what we're hoping to achieve and some context around the purpose and value of clinical supervision at this time. Some of you that are less familiar with clinical supervision might be wondering, how is it different to a coffee and a chat with a colleague? And in many ways, there are lots of familiar elements to it. But really helpfully, there are also lots of frameworks and models that can underpin clinical supervision that help you to differentiate it from that more informal process of downloading with a colleague or friend. Back in 1986, Proctor put forward this framework that I'm going to share with you now. And this is a framework that's been really highly cited and still referred to currently in lots of the more recent models. What she said was clinical supervision should have 3 defined elements, and there should be a fairly equal balance between these 3 elements in each of your clinical supervision sessions. So one of those elements or functions of clinical supervision is that it should be restorative. So this is all around how clinical supervision can help you as a practitioner respond to the distressing experiences that you're encountering in your clinical practice and the impact that that's having on you personally and professionally. And we could argue that at this current time that restorative element of clinical supervision is really high on that priority. Next, please. Another function of supervision is that it should be about a normative function, and that's really about your professionalism and the organisational standards that you're working to, and some of the challenges, maybe some of the ethical dilemmas that you're being faced with, and some of the values-based dilemmas that you're being faced with in the current times. And the normative aspect at times can feel that it dominates clinical supervision. So some people talk about having experienced clinical supervision as more of a management supervision, where it feels like you're being checked upon to see that you're abiding by certain rules and regulations. We would really encourage clinical supervisors to think of normative function more about encouraging people to think about their professional responsibilities and how that impacts upon the care that they're providing in the current times. Next, please. And finally, it's the formative element, and the formative is really about the learning. It's about the professional development, and that can be, as Tony said, from sharing experiences that you have had in the past and your knowledge, but it can also be about identifying areas for further study or development for the supervisee as well. So as I said before, Proctor says that all of our clinical supervision sessions should have a fairly equal balance of these three elements. Could I have the next slide, please? So as I mentioned, it's really significant at this current time that the restorative element is really high on that profile and priority of the clinical supervision session. Next, please. And that restorative element is very much focused on the interpersonal aspect of clinical supervision, and it is very much, you could call restorative supportive. It's very much about that supportive function. Next, please. As Tony mentioned before, we know that the current situations that people are dealing with in their clinical practice are unique and unusual in terms of the level of death and dying people are experiencing, how they're there for people if their loved ones aren't available or aren't able to attend because of social distancing regulations, and also the physical and emotional burden of the PPE and all of those kind of regulations that are in place in terms of practice. In the support sessions that I've been providing at the Florence Nightingale Foundation, what I've learned is that we can't assume that any one person's experience is the same. And what's described here might feel familiar for some people that are listening today, but others are experiencing completely different emotional consequences to their response to COVID-19, and that might be about working remotely and delivering interventions over the phone and the challenges that brings. So it really does emphasise that to be there and respond to that person from their unique position is incredibly important. Next, please. And just finally to say around the restorative function, there is more evidence in this area to show the value of clinical supervision. So there's evidence that says that if we can adequately support our staff in this type of a forum, they will have the ability to sustain their compassionate care towards their patients and their service users. It's also shown to reduce what's known as absenteeism, which is people being at work even though actually they're not really well enough to be there, and also to improve their professional quality of life, so their satisfaction and reward that they gain from their working role. Next slide, please. So as Tony's already mentioned, it's really important that we differentiate clinical supervision from counselling or more psychological interventions. There are many people that won't require that level of intervention, and actually clinical supervision as described just there will be enough to hold that challenge of emotion that they're experiencing. So if I could just have the next part of that slide, please. It's important just to differentiate that, and you as a clinical supervisor or as a supervisee to know that there is a difference, and where potentially clinical supervision can start to move into counselling, what you can do to address that. So if we think that clinical supervision is about reflection and review of clinical practice, it's thinking about difficult situations and how you might respond to them differently in a supportive environment which enables your professional development. Next part, please. However, if you are identifying that either you as the supervisee or the supervisor are recognising that actually the emotional distress you're experiencing is having a negative impact on you personally, socially, and leading to more psychological problems, that's when we would really recommend that you have some resources available to you where you can signpost somebody to counselling support or psychological support. And the links that Tony gave at the beginning of this presentation, NHS people and Skills for Care have a whole suite of interventions that are freely available to staff at this current time. Next slide, please. And just finally from me, Tony's mentioned this already, but we really want to emphasise that if you are going to be offering support as a supervisor, to think before you do that about how you will gain support yourself. So somebody perhaps who was also acting the supervisory role. Kath's going to talk a little bit in a moment about what a community of practice might offer around clinical supervision, and that may well be a resource that you can access to gather some support yourself. And that's really about understanding that by hearing other people's distress and offering a containing space, that you also will need some support within that role. And that's all from me. I'm going to hand over to Kath now.
Thank you very much, Gemma. Yes, we started to think when we were putting this webinar together around how do you do this when we've got so limited resources, there's very few staff on the ground. And I started to look around and to think about where the best place is in relation to, Tony's already talked about his experience and the length of time that many of our staff have been working in services, as well as the fact that we have lost a lot of retired nurses. And I became very aware of the friendship bench, which for some people who are from Zimbabwe and other parts of Africa, they will know that it's actually provided a wonderful approach to therapy using listening and problem-solving therapies by the fact that they trained lay counsellor grandmothers or grandparents, and in this instance I'm thinking about retired nurses, and they were designed to take time out to sit and breathe and talk or think about your own or your peers' mental health. And it's used as a psychological intervention to actually address depression. And it is an evidence-based practice in that they used this evidence-based therapy, and in order to reduce the numbers of people depressed in Zimbabwe, because they didn't have enough psychiatrists or enough nurses or anybody, and they needed to tap into the local communities in exactly the way that we're thinking about now. How do we tap in to the local resources and the people around you? So we wanted to, it acted as a tool to inspire and augmenting existing mental health awareness efforts. It's been rolled out now in Canada, New York, and also in other parts of Africa and in Mali. And it's just an idea to think, you know, what would a friendship bench offer? A friendship bench would offer an opportunity to find somebody and or a community of practice. Can we just go on to the next slide, please? And through the process of sharing information and experiences, members of those community experiences can learn from each other and develop personally and professionally. They will be an encouragement to put your own oxygen mask on before helping others. And we've also thought about how this might work, and we'd like, we know there's a lot of good practice going on out there, and we also know that we'd really like to tap in and hear of those stories. So I'm sure in the questions and answers sessions, people will be able to share those on the chat bit. But what we thought about doing next is to re-meet in 6 weeks' time, where you can tell us what the issue was that you were trying to solve in relation to clinical supervision, and what you did, and how then did it go, and what was the main learning from doing this. And I hope there will be an opportunity for potentially some people who are listening from this who are managing trusts and organisations and care homes, as Tony has indicated, that would provide us with some learning and also some ideas about how they've tapped into our retired nurses' expertise in this way. Over back to you, Jess.
Lovely. Thank you everyone for that presentation. I was certainly finding it really helpful. So just a reminder to everyone that this session is recorded, so you will be able to catch everything if you haven't quite made notes over certain bits and bobs. Now we will return to that what next slide at the end, because it's kind of like a bit of a I don't want to say homework, but kind of something for us to come back to. So with this webinar in the series, we are going to revisit it, but I'll tell you a bit more about that at the end. So next up, we have a few prepared questions for some of our panelists. And once we're through those, then we will go and ask some of the questions that have been submitted by our audience.
So, Jess, before we go on, I'm just very mindful that Antonia and Phil were going to contribute their points around their lived experience of supervision. So forgive me for interrupting.
That's fine. That's absolutely fine, Kath. So yeah, okay, so we'll do our lived experience bit after the Q&A, because I'm hoping that in the answers that these guys give, that they'll be able to go through that, and then we'll be able to expand afterwards. Thanks, Kath. So our first question is aimed at Ellie from Health Education England. Now, Ellie, what role does supervision have in retaining staff?
Thanks, Jess. So just to start off, I'm sure it'll come as no surprise to anybody on the call that retention is a real area of concern for both health and social care. Wherever you work, be it the private sector, the NHS or voluntary, it's long been a worry that we do lose far more nurses than we feel we should do, really. And the Royal College of Nursing has done many a report every year. It consults its members, and you know, a common theme that comes up is, why do people leave? Why do we lose people from the workforce? And the same themes come through time and time again. People say they didn't feel listened to, they didn't feel cared for, and they didn't feel supported. And as you've just heard, clinical supervision is absolutely the perfect place where you can go, you have that private time, it's one-to-one, you feel listened to and you feel supported, and somebody's absolutely valuing and hearing what you're saying. But even better than that, they're then giving you the skills to go away and help tackle the issues that you brought to supervision, give you some new tools to deal with it. And as I mentioned earlier, I think I've seen as well, it works so brilliantly with myself and colleagues about leaving work at work. We all know when you've had that bad shift or that bad experience and you sat at home and 3 hours later you're still worrying about it, and that is so draining. And this is where I think supervision is so important for us all, to be able to leave work at work, go home and have a really good work-life balance, and that really is essential. Thank you.
Thank you, Ellie. That was great. So our next question is for Tony and Kath, if you wouldn't mind. So if the organisation that you're working in doesn't make a provision for supervision, how can individuals push for it?
Hi, it's Tony here. Well, a couple of things really. Organisations are always difficult to talk to. So for non-clinicians, sometimes it's hard to understand the value of clinical supervision. So you need to help them understand, I guess, in the first place. Organisations are easily scared. So if you tell them that it's actually a requirement of the Nursing and Midwifery Council, and also CQC, for example, will look for evidence of supervision now. So organisationally, it's important for them to be able to show evidence that people can access and use clinical supervision.
I would just add to that I think most of the patients and the public would be incredibly shocked if they knew that nurses weren't getting this regularly, and also that if you are in an organisation that isn't prioritising it, is actually to find your allies. The communities of practice that I highlighted, and also the friendship benches are a unique way to be able to perhaps create your own, and then also finding like-minded managers and other people within the organisation who will be thinking and feeling exactly the same way that you are, and that they will want to help because they want you to stay at work, they want you to feel happy, and we know that happy staff equates to happy patients, and likewise that's the best way of promoting recovery. So there are people out there, you have got allies and friends, and also the network that you can find through the RCN, through our professional networks. We know that we can actually link people up and have that opportunity through such things like this now, because of course we are more able to meet through cyber world. I have just been recently running supervision sessions in my own trust across much wider areas than I would have been normally, because normally I'm stuck in traffic and I normally can't get to the community teams that I would have done previously. So this has provided me with a unique opportunity. So use what we have suddenly found to be very, very liberating.
Amazing, thank you. And I would definitely agree with the whole utilising the tools that we have available to us, you know, now more than ever with the virtual equipment we've got. So Antonia, the next question's for you. As an individual with lived experience, can you tell me about your personal experience of accessing clinical supervision, please?
Thank you, Jess. Well, I have to say in my previous work, which was in education establishment, we used to call supervision one-to-ones, and I think because of my situation, I did find it quite a tough ordeal having one-to-ones, because I felt that it was more of an opportunity for my manager to really sort of have a go at me, rather than improving, talking about my practice and helping me to improve it. I think, but now coming out the other side, have therapy, my outlook is somewhat different, and I think I would now go into it and use it as a time to focus on my personal and professional development, and help to reflect on my own practice, and focusing on making it a safe and confidential environment to discuss my personal and professional response to my work. And I think for me that is very important, because now that I'll be working in the healthcare sector, I think, having had little experience, I do have to walk a bit of a fine line between listening to what the patients are saying to me and being an advocate for them, and actually thinking about my role as a healthcare worker in that situation.
Lovely, thank you so much for that. My next question is for Phil. Now, Phil, what influence do you think that well-utilised clinical supervision can have on direct patient care?
Thanks, Jess. I think for me, this is a really, really important question, because ultimately we should be trying to do as much as we can to improve patient kind of experience, patient services, and you know, ultimately patient care and the outcomes that they receive. And I think for me, supervision is that safe space. It's that supportive space that allows people to have that time to understand, you know, situations, conversations, and their kind of journey, really, their clinical journey in the services that they're providing. I think it's vital that staff are given this space. We're dealing with more and more complex kind of need from people, you know, certainly in mental health, that the acuity of patients and how poorly they are has gone up, you know, over the years to lots of degrees. And I think unless we give space to nurses and clinical people to understand, you know, the process that they're going through, I think they can become too much sometimes. And I think it's really vital that we have that. And I think it's even more vital that this is seen as, we do a lot in mental health, and lots of people will know, around kind of peer support really, and it's having that shared experience of similar kind of situations and similar services. And I think that's so powerful, and it brings so much empathy to a conversation that can support somebody's practice going forward.
Amazing. Thank you very much, Phil. And last but not least, for our prepared questions, is over to Emma. How have you found clinical supervision helpful at a more senior level?
Yeah, thanks, Jess, and hello everyone again. So I would say that I have found clinical supervision to be absolutely vital throughout my career. It's something that I always valued. I always valued the space, and I think, as Phil just said there, about that safe space to kind of share your concerns, your worries, but also I think it's worth remembering that clinical supervision is also an opportunity to share what's worked well, and to share some of those celebratory moments or those glimpses where that you're really proud of. I would hate for people to think that clinical supervision is always about working through knotty problems. Sometimes it's also reflecting on, like I said, the good. And certainly, as someone that's always maintained clinical practice, for me, clinical supervision has always been a must-do. It's something you really have to prioritise. You have to make the time for, and you have to take personal responsibility for that. Actually, there's certainly been times in my career where it's very difficult. There's lots of competing priorities, and it would be easy to put other things first or other people first. But I know, for me personally, for me professionally, that time and that space to sit down and really reflect and think through either my practice or the decisions that I've made, particularly as I have moved up the ranks, if you like, and you're having to make big decisions that affect lots of people. It's really important that you have that critical friend, that critical space. And sometimes our roles can be lonely. Some of us work in nursing roles that are in the community. We're not necessarily have a team around us, and particularly at the moment through COVID, a lot of us are working in perhaps a virtual way where we're disconnected. And certainly for me, in this most recent role, the first thing that I did when my role shifted to take on a more national role in the COVID response team was to ensure and link back up with my mentor, and actually to increase my clinical supervision. So I know one of the questions that's come up has been how often. So I've always had clinical supervision around every 4 to 6 weeks, roughly, and different trusts and providers will have policies on that. But I also recognise that at different times in my career I needed it more. And so at the moment I'm having some time every 2 weeks. And sometimes that is just a check-in, but it's such a safety net for me knowing that that's there if I need it. And I think the other thing I would also say, for those of us that are in leadership positions, it's really important that we role model that clinical supervision is important, and that we kind of walk the walk and people see our actions, but also that we're in positions of influence. And I don't take that lightly, that I also see that in my position now particularly, a massive part of that is enabling and creating the culture and influencing to enable all nurses to know that this is a vital part of their day, and to create other systems and NHS leaders to support that. I think I'll stop waffling there because you'll probably get me on my soapbox, as you can tell, and there'll be no time for anyone else. But I can't say how important it is, and I suppose my final thing is I don't think I would be where I am and have maintained both clinical practice but my own mental well-being without it. That's how important it is.
Thank you, Emma, and I don't think you're waffling at all. It's good that we've got so many people that are so passionate about it together. It's really good and really exciting. But yeah, thank you. So that's the end of our pre-prepared questions. But before I move on to some of the questions we've received from the audience, I wondered whether we could go back to Phil and Antonia if there was anything additional you wanted to add in there, because I know our questions were quite specific and I do want to make sure your voice is heard. So maybe Phil first.
Yeah, I think for me it's it's the kind of one of the cornerstones really of how you deliver clinical care. I think it's, like Emma said, so eloquently, really, it is that space to share the good and the bad. Really, I think it should be the space that you grow and develop, and I think sometimes the supervisee can get as much out of it as the person being supervised. And I think it is about that kind of journey. You know, people use the journey word a lot, don't they? But I think it is about, you know, how you have the safe space to have those conversations to support ultimately clinical practice, ultimately improving services, improving patient care. And I think it's vital in the work that nurses and clinicians do. They've got to have that space. It's just so vital that they have that space to allow them to kind of move forward in the very stressful and very difficult situations that lots of nurses find themselves in.
Thanks, Phil. And Antonia?
Yes, thanks, Jess. Yes, I would agree totally with Phil about the learning. It will be both ways, both for the supervisee and the supervisor. And I think it's probably important for in that safe space that we don't think that one supervisor maybe is of what they have to say is of more importance than what the supervisee has to say. And I would also talk about reflection and how important it is as part of the learning process. Having lived experience, reflecting is something I've had to learn. I struggled with it a lot at the beginning, but now it's getting better, and I think it's a huge tool in improving your mental health.
Lovely, thank you, Antonia. And I would agree that reflection is, I personally have not found it easy at all as a student, learning to do it from when I was in first year to now nearly being qualified. But I have noticed the more that I found a model that works for me, and I do it so regularly now because it helps me kind of put that to bed, and then I can, have my personal life and work life a bit more separate. But enough about me. We are going to go over to questions from our audience. So our first question, I'm going to aim this at Gemma, if that's okay. Gemma, how do you think we could use supervision to inspire the best in every student, especially those that want to go into what could be seen as an alternative direction, like research, for example?
Sorry, Jess, I was kicked out of the meeting. Could you repeat the question?
Yeah, absolutely. No worries at all. So, Gemma, question for you is, how could you use supervision to inspire the best in every student, especially those that want to go into what could be seen as an alternative direction, for example, a career in research?
Oh, that's such an interesting question. I think one of the things that clinical supervision offers is a space to explore, and to do that in a safe environment where there's no judgments and there's no predefined pathways that people are having to meet certain requirements or to please people that are perhaps going to be assessing them in the future. So I think particularly for students, identifying clinical supervision as an area to say the things that their ambitions, their worries, their fears, thinking about some of the strategies that they may use in order to reach some of those ambitions. It's exactly the right place for that to happen. So my suggestion is with clinical supervision is to be facilitative in approach, non-directive, not to assume that everyone sat around your table has a particular journey ahead of them, and to ask those very open questions, and also to encourage others within the group to validate experiences, share their own interests and ambitions as well. And usually what you find is that you've assumed that people are going down what might be seen as a very traditional path, but actually you realise everyone sat around that table has got different ambitions and different goals that they're hoping to achieve from their nursing career.
Jess?
Hello.
Ensure that people don't feel there's a judgment.
Can I Can I just add to that a little bit? I think there's a unique opportunity as a mental health nurse. I am a researcher. I ask open questions and I ask about who that person is. So every person is a study in themselves. Every family that I come to is a study in themselves, and therefore you can automatically ask, what's the hypothesis here? What works for you? And I think those unique research questions are the ones that we are to be asking of our individuals as well as the families and the systems that they work in.
Thank you for that. Kath, I love being on a webinar with you.
Thanks.
And you can't, that's fine, I like it. Thank you. So a question for Ellie. Ellie, if your trust has a lack of clinical supervisors, how would you suggest accessing clinical supervision independently?
Oh, good question. I think it's an interesting one, because I know when I first trained, there was quite a focus on you had to get clinical supervision where you work. You weren't allowed to even consider getting it anywhere else. And I think now, as Tony mentioned earlier, we've got things like, you know, we have webinars like this, we can get on Teams, you could potentially connect to a supervisor anywhere in England, the UK or the world if you wanted to. And I think we've got more ability than ever before to think creatively about who could be our supervisor. And I think Antonio alluded to this as well, is that sometimes the less good person to be your supervisor is somebody who's your manager, because quickly that could just descend into line management and it's not supervision. So actually what's more important is find somebody you feel comfortable with, you trust, and you can open up to. And like I say, and you can do that, like I'm in the Royal College of Nursing Mental Health Forum. There's all sorts of other forums where you can meet like-minded people, develop that relationship and have that conversation about, would you be my supervisor? And it could be a peer, or it could be somebody more senior that you wanted to aspire to that level. So I think there's so much more choice now than ever before, that your imagination is the limit to a certain extent when it comes to identifying a supervisor.
Some great tips there. Thank you very much, Ellie. I know that Florence Nightingale Foundation are also offering sessions as well, and that was another part of what kind of led to this too. So I know others are available, but personally I found that really beneficial, especially as a student who's employed at the moment, and you know, I was kind of stuck with where do I go for this kind of support. So yeah, seek it out, I guess, is the top tip there. My next question is for Tony. Tony, I'm aware that many of my mental health colleagues are having regular clinical supervision. However, as a newly qualified nurse, I'm not aware of clinical supervision happening at any other time than at revalidation. Is this something that should be provided for all fields of nursing?
Yes. It comes as part of our way of thinking of as mental health nurses, to seek this and use it. When we did our big national evaluation study some 15 years ago, it was really difficult to find adult nurses, general nurses receiving supervision, and when it was put to them that it was possible, they were terribly keen to have it, but it was always much more hard to access. So I think that, you know, as students newly qualify, you could reasonably expect your employer to find time for you, especially as a newly qualified person, to receive clinical supervision, and it should be available in all specialities. There's nothing more or less stressful about working in mental health or acute general care or learning disabilities. They all have an equal measure of difficulties and pressures that people need to try and resolve with an experienced other.
Thank you, Tony. Kath, over to you. It does kind of lead on from what Emma was saying earlier, but a question we've had is, could senior leadership use supervision to nurture our future leaders, and how could these opportunities manifest themselves?
You're muted, Kath.
I was saying words of wisdom, and unfortunately nobody heard them. So I better get on with answering properly. The thing that I said, of course they should and must, in order to be able to consider what's out there. I think all leaders know somebody, and every leader, in the way that Emma has just talked about, has somebody in their lifeboat. I have had a lifeboat since I started nursing. I've had different people at different times. I've thrown some out, brought them back in, but they've all been there for me. And we do work, even through COVID and whatever. Nursing is very much a roller coaster. So the highs are great, the lows are crap. And it's those times where I have been deeply grateful to my colleagues and my peers who have said, this is how we do it. And unfortunately, because Beatrice Stevens isn't on the line, she was one of the most pivotal psychotherapist mental health nurses that I worked with at the Maudsley. And she said something extremely important that we have to remember as leaders and whatever we are. I'll never forget her saying to me, remember how you felt in the morning. You got up and felt bright, you felt lively, and by the time you got home, you were probably exhausted. And that's other people's stuff. And it's other people's stuff that we need to think about how those leaders can promote the understanding that we need to be able to cleanse ourselves in order to be able to get to be able to continue working, especially in these challenging times.
Thanks, Kath. I'm conscious of time.
Oh,
yes.
Sorry, can I just add? Is it okay just to add one point to that about the senior leaders?
Mm.
I suppose the other thing I will say is I think there still is a little bit of anxiety and fear within senior leaders that clinical supervision is somehow admitting that you can't do your job or that you need help, and that can be really difficult. And I guess I just want to use this opportunity to call that out a little bit. I always remember when I first qualified, and it was a long time ago, admittedly, but my G grade CPN who was supervising me telling me he didn't need supervision anymore because he was a G grade. And although that is nearly 25 years ago, I do think there is still that little bit of culture that people think as you get more senior, you don't need it anymore, and therefore it's quite difficult to ask for. So I think there is a separate piece around enabling senior leaders themselves to access and do that role modelling, which is absolutely critical. There absolutely is a place for them in terms of nurturing the future, but there is much more vital is that they're role modelling, and they're also enabling others to have the supervision they need and championing it for them. So sorry to butt in, but I just thought it was an important point to know.
That's absolutely fine. Thank you very much, Emma. That actually leads me quite nicely onto the next question about you said there about making time for it. But, you know, we all know that for nursing, we're in a staffing crisis. So even before COVID happened. So when staffing is short, how would you advise us to make that time for clinical supervision? Because I know colleagues who have had it cancelled for months on end because, you know, when it's come to that point, there's just not enough staff. They've been pulled in other directions. So do you have any advice to avoid that and to prioritise that clinical supervision time? That's for you, Emma.
I thought that nice tricky one might come to me. I suppose there's two reflections on that really, and the first one is, isn't it amazing how nurses always seem to be the group of professionals that don't engage in supervision, where other professionals seem to have got it sorted, and I'm always quite envious of that. I think there is something for us making sure we do prioritise it, and it is seen as critical as seeing that patient, and I know that can be really difficult. But there are ways of factoring in, and I know that when I've worked on wards and rostering, it was factored in as a clinical task in the same way that patient care was. And so there is something about being really proactive, about pre-planning, about thinking differently about how we do supervision. Like Kath, I've been quite amazed at embracing the virtual clinical supervision routes and how that can really bring people together in different ways rather than necessarily having to be face-to-face. I think it's a difficult issue because there are staffing shortages. It's very difficult if you're the only nurse in charge. But there is something about really thinking together about how we make time differently and how we utilise our time differently to prioritise this. If we don't do it as individuals and collectively as peers and teams, no one else is going to do it for us. And I know that's probably not an easy answer. I wish I could say that I'm going to magically have the 50,000 nurses, which would mean we've all got time. And of course, it's not that easy as we would have done it. But I do believe there are some simple processes, some symptom changes, some different ways of working, which would enable us to perhaps think about it in a different and more flexible way.
Jess, can I add something just to that point?
Yeah.
It's to do with the fact that there's no I in team, and I don't think nurses are very proactive in explaining to the other team members that in actual fact we need oxygen too. The wonderful teams that I've worked in have really helped each other out, and I think there's something, I don't think the psychiatrists that we work with or some of the occupational therapists or other members of the team, I don't think they genuinely know that that's not happening for us. And I think this is a time for us to say, we own this bit, and can you help us out? Because in the same way that a patient might ask for help, it's absolutely fine to say, I need to have this in order to continue to care.
Kath, it's like you can read the questions that are coming up next. Thank you. I know, right? The next question is actually more of an open one, to be honest, but anyone feel free to answer. Is clinical supervision proactive or reactive?
It's Ellie, it should be both, surely. I mean, it does feel a bit like if it's reactive, in some ways it's almost too late because you're waiting for there to be such an issue that you're thinking, I need to talk. It's always the way, isn't it? It's always much better to be proactive than reactive, and there will always be situations when you're reactive. But I think it also goes back to Kath's point that I think as nurses, we're really brilliant at coping, and we always cope, and we keep on coping, and we keep on going, and we think that's a sign of strength that we keep on going. And actually, I think Antonio's all mentioned this about reflection, that part of our reflection and part of good reflection should be sometimes saying, I'm really struggling, or I know that if I don't talk about this, I'm going to struggle. So I think there's a responsibility on us as well to think proactive is better. This is part of our reflection. We need to recognise when we know we're going to struggle or we are struggling, and be honest and realise it's not a sign of weakness, like Emma was just saying. It's actually a really positive thing to say this is not a great time, or I know it's not going to be a good time, and some help will be brilliant right now.
I think when you're beginning with supervision, reactive is easier because you're dealing with something that you've experienced, and you seek advice and help and support about that. But then from that, don't you build up your proactive agenda from that? You're thinking ahead rather than behind. But to get conversations going, and when you've first chosen your supervisor, then discussion about reacting to particular incidents is always the easier, I think.
Would anyone else like to add about proactive versus reactive?
Could I just add, Jess, there's something I think about clinical supervision being seen as that continuing professional development as well. So we've spoken a lot about that restorative element, which would probably be seen as the reactive aspect, but there's also that learning element to it. There's also that professional development aspect that's around our ethical principles and our code of conduct and those types of things as well. And in that sense, it is about that being part of our routine. We engage in it in order to improve ourselves and develop ourselves as practitioners.
Thank you. That's a really good point, Gemma. I'm really sorry, guys, but our time is not our friend right now. But I'm going to slip one more in before we kind of sum up, because I can see someone who submitted a question that is a question that I would probably ask, because I'm a really practical person, and they've just asked, is there a template that can be followed, or is it more personalised? So that's someone that's clearly really keen to get going, but they don't know where to start. So does anyone have any advice over that? I saw Gemma put her hand up there.
Yeah, we've actually, at the end of the presentation, we've included some links to some resources that people might want to investigate, and there's lots of different templates and models that really is about your preference and also your aims and objectives for clinical supervision. So definitely not a one size fits all. I think it's about seeking out and looking into the different approaches. But there's loads and loads of resources out there. We've highlighted just a few.
Thank you, Gemma. Oh, someone else to add? No. That's so we do have resources, as Gemma has said, kind of signposting you to some great ones, and I know there's a bit of time before we are able to release the slides, so for anyone who wants to access them ASAP, we will tweet them out on the @RCN Students account, so you can get those as soon as possible. So I'm really sorry everyone, but I'm going to have to draw the questions to a close. But before I sum up, I know that, you know, when we're in these discussions, sometimes something comes into your head and you really want to get it out there. So I'm just going to hand it back over to our panelists. Is there anything that you're really burning to say?
Jess, it was just on the question of if organisations and trusts are not forthcoming, should I say, choosing my words wisely, about supporting supervision, then I think it is about the individual, but then it's about the collective, but also there's things like Speak Up Guardians and, you know, deputy directors of nursing that are tasked with some of these things. And I think it's about finding allies and using any, you know, if you really feel that you're not being supportive and it's not happening, I would just really encourage people to ask those questions. Don't be fearful of that. You know, like people said, and like Tony said, you know, it's part of guidelines, it's part of NMC, it's part of CQC. You know, really encourage people to you know, push organisations and trusts to get to that place of offering that support for individuals. I think it's really vital.
Thank you, Phil. Would anyone else like to say anything else right now before we sum up?
I just saw a little other question in my side panel, which said, does the panel think that COVID supervision is more important than ever? And it's the strangeness of all that, isn't it? You know, I mean, how on earth people walked through the door of those newly built hospital facilities in Manchester and in London. What was the atmosphere? What was the experience? What was that like? It must have been terrifying for everybody. People who thought it wasn't are crazy. So yeah, I think it's really important at the moment, and we ought to be collecting some intelligence on how people coped and managed with all of those new things that they had to do.
Absolutely, Tony. And yeah.
I just think absolutely, Tony, and I'm thinking that of the team I work with at South West London in St George's, the very first day after we went into lockdown, we had our first meeting, and I was so impressed with everybody that they had come, and we sat around in a sort of state of shock, pretending everything was all right. And then very wisely, one of the more experienced nurses said, "I feel terrible, and this is really frightening me." And how cathartic that was in order to be able to us to rebuild. We talked about it. It took us only a couple of minutes or, you know, to just throw those processes out. And from that moment on, we felt stronger. So what that taught me was it's absolutely fine to say you're vulnerable, be around people, and then you rebuild. That's what this is about. We rebuild and we're stronger if we talk about our vulnerabilities and help problem solve them with each other.
It does feel like a real opportunity, I think, as well at this time, because as lots of people have said, it's often been clinical supervision has been seen in the mental health nursing domain, the other fields of nursing, despite the fact that they're dealing with those emotional consequences of their work on a day-to-day basis, haven't necessarily seen it as relevant or as important for them, and it's not been as well provided. But actually, the COVID response has really brought staff wellbeing so much higher on the agenda. So I think it's a wasted opportunity if we don't use this momentum now and say that this should be part of what we do. You know, we've said in tweets, this isn't a nice to do, this is an absolute essential part of how we practice and in a safe way, and enabling us to continue to practice as well. Thank
you, Gemma. So I am really sorry, guys, but I could continue talking with you guys all night. I really could. But I think I'm sure most of you want to get into your pajamas and get a bit comfy now. So I would like to say a huge thank you to all of our guest panelists this evening, to Tony, to Kath, to Gemma, Antonia, Ellie, Phil, Emma, and of course Beatrice. I know you're there. Thank you so much as well. For those of you who weren't with us at the start, our student member of the Trade Union Committee, Heather Massey, has been helping in the background and fielding your questions for me. So a huge thank you to Heather. Another huge thank you to the AV team who make all this happen for us. And last but by no means least, a thank you to our audience that are tuning in with us live this evening, and those of you who are going to catch up on YouTube as well. Now, I'm going to ask a favour of our AV team if they could possibly pop up the what next slide again, pretty please, because this, as I've said, this webinar is slightly different to the others we'll be doing because we are going to be running a follow-up session which will be more interactive, and we're going to ask our attendees and those of you who are watching this on YouTube afterwards, we're inviting you to come back to us in 6 weeks' time and have more of an interactive session and to share, you know, your best practice. So for those of you who have been doing this for ages, it's been working really well, please please share that with us. But also, I would also like to invite those of you who haven't done it before, but you have identified that there is a need for it, and don't be afraid to start doing it. So to Hannah, whose tweet that this all kind of originated from, I would, if you would like to, I would really encourage you to try and do this in your workplace. By all means, contact us for support. But we would really like to hear from those kind of people as well who have never done this before, and we can all learn together. So that next webinar is going to be on the 16th of July. We will share all of those details with you via our channels as well, including the slides that we've put out, the recordings. You can access all those resources. As I've said, we'll tweet them too from RCN Students, and all of our guests will share them as well. So you should hopefully be able to access those. Any questions that haven't been answered this evening, or if you've got more questions as well, you know, we invite you to send them our way at RCN Students, and we will send those out to our guest panelists and get a question and answer document published, so that you have that information readily available to you. So I think I have more or less summed that up. I feel like I'm waffling now, but yeah, a massive thank you to everyone for your contributions this evening. It's been a really, really interesting conversation. Our next webinar is due to be held tomorrow, and that is on your money situation in COVID, and how, as student nurses, you know, what support is available to you, any impacts if you've gone on a extended paid clinical placement that may have on, you know, your future loan applications, tax credits, all of that kind of stuff. And that's what we're going to be discussing tomorrow. So that is us done for tonight, everyone. So thank you
so much, Jess.
Thanks, Jess.
Thank you. You've shared that fantastically. Thank you. Let's just hope everybody can get out there, get their next supervision session.
Yeah.
Well done.
Well done.
Well done. Thank you.
Thank you.